Jasmine. Our final speaker today is Dr. Heidi Syropoulos, a physician leader with strong experience in complex chronic care management and working with clinicians and payers alike to maintain quality and cost measures. She is the medical director for Independence Blue Cross's Medicare Advantage plans, and we're so grateful to have her with us today. We've heard a lot about caregiving, and we're excited to hear more about their program.
Great. Thanks, Catherine. Next slide. So what I'm going to be talking today really is the title is the lessons from our successful Medicare Advantage program. Really, I could talk for 30 to 40 minutes, but of course I've got 15, so I've consolidated and decreased the slides that I would normally present. This is really a snapshot into our caregiver support initiative that we started about 1.5 years ago through our Medicare Advantage plans. But before I even get into the caregiver initiative, I want to talk about what prompted us to start. What was the history behind our interest in providing and starting a caregiver pilot? So I really want to mention what an age-friendly health system is. I came to the plan in 2016 after I had practiced geriatrics for 30 years. It was an interesting transition to going from taking care of individuals to now taking care of groups, trying to figure out how I could navigate within this system and figuring out what was my clinical vision for the Medicare Advantage plans as the medical director for Medicare in our health plan. And in 2018, there was really a groundbreaking article published in my trade journal, the Journal of American Geriatric Society, that talked about an age-friendly health system, new model of care called the 4 M's. This comes out of the necessity and the urgency of the United States, where we see we're currently living in what many people call the silver tsunami. We're just a burgeoning elderly population that continues to grow in the United States, not just the US, all of the Western countries. And we really don't have a concise and simple model of care that can meet the challenges of caring for this growing population. They set about and did a study and involved 5 premier very large health systems that looked at this model of care with the intent that following an essential set of evidence-based practices cause no harm and actually aligned with what matters to the older adult and their caregivers. And those 4 M's essentially are what matters, medications, mentation or your mind, which include screening and treatment for depression, delirium, or dementia, and mobility. The 3 bottom M's, medication, mentation, and mobility, really are meant to be addressed and managed across all sites of care, but always in the context of what matters. So really the 4th M of what matters is really the most important. Does the patient and has the patient had a conversation with their caregivers and their providers as to what's most important to them? Have they completed advanced care and planning documents? Have they talked about their goals of care? So this article really just was from the perspective of providers, doctors, practices, hospitals, nursing homes. But what about health plans? When I read that article, my first thought was, well, but the health plan and the payers really need to be invested in this age-friendly health system, in particular a Medicare Advantage company, of course. And the rationale, even more importantly, for independence, for focusing on the 4 M's, is that 49% of our population is over the age of 75. It is true that Medicare, since its inception in the 60s, has improved in terms of chronic condition management for our older adults. We've gotten better at controlling blood pressure and decreasing stroke prevalence. We've gotten better at prevention in some ways, improving vaccinations, managing diabetes and chronic illnesses. But almost half of HEDIS and CMS star ratings exclude people over the age of 75, and star ratings are essentially silent on the management of syndromes of aging. So as a result of this, IBX takes this model of care very seriously. We've identified ways to enhance management of advanced illness, advanced care planning, focusing on ways to deprescribe, and caregiver support, along with other elements of geriatric medicine. We consider what those principles that define age-friendly health plans for independence members is that we feel that we should be accountable for the alignment, financing, and outcomes of a geriatric model of care. It should be based on the 4 M's of age-friendly care, should be economically viable under Medicare payment, focused on patient choice and quality measurement, and we recognize that for geriatric medicine, having a dedicated and loving caregiver is a key factor for good health. So how did our caregiver support start? It really started in a post-acute program that we started in, I want to say 2021. My vice president for STARS and risk adjustment contacted me and said, we've been reviewing our mock CAP survey results, and we found that the members who rated us the worst in the health plan, and in particular in the measure that asked patients, when you needed care the most, did you receive it? Those members who rated us the worst had all been either admitted to the hospital or in a SNF in the last 6 to 12 months. And he said, does that make sense to you? And I said, well, yes, definitely. Coming out of the hospital or coming out of a nursing home is a tremendous pain point for a patient. So we internally designed our own post-acute care program. It included case managers outreaching to everybody who'd been in the hospital or the nursing home, having a handful of utilization management nurses at some of our high volume SNFs, and also creating quality scorecards for our home health agencies and SNFs. But in part of that post-acute care program was born our initiative and a relationship with a vendor called Carallel, who we offered caregiver support to our members from. So the pilot started in 2023, and that first pilot, as I mentioned, was really offering caregiver support only to those members who were in our post-acute care initiative. They'd been contacted by case managers, or they received a flyer in the mail. Year 2, which is now 7 months old, we have expanded that target membership to include all members who are enrolled or engaged in case management, and any member who has a diagnosis of dementia. Additionally, we introduced a pre and post assessment to measure impact on burden and resilience. The burden scale is the Zarit burden scale that goes from 0 to 16. A high Zarit score would be 8. Our pre-score for our caregivers was 10.5, so highly burdened caregivers. Post scores were down to 7.2, so we clearly had a measurable impact in burden. Resilience is measured by a Connor-Davidson scale, which is on a scale of 0 to 10. It's really a scale that measures people's ability to cope under stress. And the national average of anybody, even if you're not a caregiver, that score is about 7. And the lower the score, the less resilient you are. Our pre-caregiver support scores were like 5.5, and post they were up to 6.5, close to the national average. So what does Carallel do? 3 broad and general things that they offer, solutions that they offer. One is what we call expert advocates. These are people that talk on the phone with members and assist them with a variety of different things. Then we have what we call intuitive digital support. This is a platform people can contact and chat online if they prefer to text in that regard. And then they engage caregivers in a third way, like offering webinars, offering virtual support groups. They send content kits for social media and things like that. This slide actually is a composite slide that looks at Carallel's overarching outcomes from many different Medicare Advantage plans. Much of this was found to be the same within Independence Blue Cross. The need, 62% of seriously ill members really rely on family caregivers. The average burden score for caregivers was 9.5 for Carallel. Of course, with IBX, we were actually 10.5, so our caregivers were far more burdened. A significant percentage of caregivers have never even heard of palliative care. In terms of the experience, this really was the same for IBX as it was for any of the other Medicare Advantage plans that Carallel is contracted with. Noticed a significant increase in confidence amongst our caregivers, a decrease in feelings of isolation, and the Net Promoter Score for their entire book of business is 87. For us, it's actually 91. When caregivers engaged with Carallel, they were highly engaged and really loved the support. In terms of impact, we don't have enough caregivers at this point in the initiative to be able to make a comment on costs, but it is fair to say certainly 75% of our end users also connected to benefits and resources. This gives you an idea of the growth. Who were these members? And give you a sense when our case managers calling members who've just come out of the hospital or anything, we're talking about an outreach of maybe 9,000 to 10,000 members in a year. A significant number of these people don't have caregivers, or they don't perceive that they have a caregiver. Once they do have caregivers, it ranges and it varies from case manager to case manager. Some case managers report about 20% of their members want to be connected to Carallel, and other case managers say about 80% of their members want to. So there's some variability there. We have had about 370 total caregivers that have been involved in the initiative since the beginning, and we average about 84 users per month. Probably the nicest outcome we see here is that once you're engaged, there's at least 12 interactions per user. And this comment in the bottom right here about actions per case, what that's referring to is what are the actions that the advocate, either through texting or telephonic, is assisting the member's caregiver with. Those are things like addressing complex emotional burdens, delivering education on disease and management, referring to a fitness program to address social isolation, connecting to virtual support groups, assisting with advanced care planning documents, things like that. We divide those action groups into three main categories. One is what you might call the emotional. That's talking about self-care, assisting with relationships within the family. Another category would be called expense, which is really talking about home safety, home modifications, getting information on housing options, things like that. And then another category, what I would be calling advocacy, which is essentially managing diseases and assisting with advanced care planning. So in the end, I would say we've learned a variety of things from the initiative. We've learned that engagement really comes either telephonically or it can come from mailers. The majority of our members, caregivers, actually 66% of them do not have our health insurance. We've learned that, and actually 13% of the members who are caregivers for themselves, actually, they have no one at home and they have no children. We learned that we're able to decrease burden and increase resilience with a caregiver support program like this. And we've also learned that the program really can impact and improve the number of personal representative request forms, those HIPAA forms that are so needed for the health plan to be able to communicate with a caregiver. And also it's really improved the completion of advanced care planning. We've learned that post-acute care participation caregivers really are engaged during very intense caregiving moments, and that dementia caregivers have skewed, at least initially, into early stage engagement. And finally, I would say we've learned that and confirmed, I think we all know this, but we've really confirmed that there are multiple barriers which create really stressful caregiving. And the top three really are lack of awareness of community resources, ignoring one's health, and of course, the worst is being able to afford caregiving. Thank you.